Excellent. It's been a fantastic start to the conference so far. I think I've been attending the Oxford Africa Conference every year now since about 2012, and it never ceases to amaze me the extraordinary effort that the team puts together in bringing together a phenomenal array of speakers, attracting a dynamic crowd of delegates, and just putting on quite a show for us that's at once entertaining but also challenging. My name is Simukai Chigudu. I'm a doctoral student in international development here at the University of Oxford. I also come from a medical background, and I work, study, research, and write about global health and global health politics. And it's really my distinct honor this morning to chair today's session on reimagining global health in Africa and its diasporas. We are joined by an illustrious panel, and that is no exaggeration whatsoever, whom I'll be introducing very shortly. The format of the session will run as follows. Each of our speakers will have in the range of about 5 to 10 minutes or so to present something. Then I'll exercise moderator's privilege and ask a few questions, and then we'll open it up for a discussion to everyone. Can I just remind everyone at the outset that since we are pressed for time, to keep your comments thoughtful, piercing, but also brief. Okay, so on to introducing our panel. To my immediate right, we have Professor Kevin Marsh, who's a professor of tropical medicine here at Oxford. I actually have to sit down for this. These guys' CVs is just far too long to rattle off the tongue. Kevin is an advisor of the African Academy of Sciences and a chair of the World Health Organization's Malaria Policy Committee. He has, so many accolades. He was awarded the highly prestigious Mahidol Prize for Medicine in 2010. He had been for over 25 years the director of KEMRI, which is the Wellcome Trust Research Program in Kilifi in Kenya, and continued on that work until 2014. Kevin has a broad interest in clinical and epidemiological and immunological aspects of malaria, so truly a well-rounded global health scientist. Sitting next to Kevin, we're very lucky to have Dr. Nawal Nour, a researcher, an activist, and a practitioner. Dr. Nour works in areas surrounding female genital cutting, undoubtedly one of the most pressing and contentious issues in global health. She has spoken in numerous academic and national conferences regarding both the medical management of women who have undergone this procedure, as well as some of its wider social, political, and economic implications. She served on the FGC Task Force for the American College of Obstetrics and Gynecology. She's also received extensive training, both as an accredited obstetrician and gynecologist, affiliated with Harvard University's Brigham and Women's Hospital. She has a master's in public health. Her research and her writing has appeared in the New York Times, the Associated Press, Washington Post, National Public Radio, and so on and so forth. I could go on, but we're in a rush here. And then at my far right, we have Dr. Mosa Moshabela, who is a medical doctor with a PhD, a public health scientist working in health services, systems, and policy research, and is currently the chief medical specialist and head of rural health at the University of KwaZulu-Natal in South Africa. Prior to joining the university, Dr. Moshabela was the regional health advisor for the Millennium Villages in West and Central Africa, based at the Millennium Development Goals Center in Mali and Senegal, and affiliated with the Earth Institute at Columbia University. He is, again, as I mentioned, an interdisciplinary scientist. He works with University College London and the London School of Hygiene and Tropical Medicine, both leading centers in public and global health. So I think that will suffice for an introduction, and I'll hand over to Kevin to kick off our discussion. Thank you very much.
Yes. Okay. Do you mind if I stand up?
Please do.
I find it really hard to talk sitting down. So we were asked to reflect on the current state and the future of public health, global health. I found this really hard to do because I think the future is going to be very different for public health in Africa than the present and the past. And one of the talks I would like to have given is the one we heard from John this morning about digital health. And some of you who've heard me talk about this in the past will know that I actually think there's going to be a massive transformation. But what I'm actually going to do, because we were asked to give a case history, I'm going to actually talk about something far more simple and I think very optimistic. And it's a different picture to the picture many people have when they talk about health in Africa. I'm going to try and persuade you that in many important ways, the last 20 years have seen a dramatic improvement in health and will continue to do so. And that the ways of achieving that are very simple and very robust and easily achievable. So I'm going to do this from a personal point of view. As Simukai said, my day job is a researcher. I've lived for the last 27 years on the coast of Kenya. But the other job I do when I'm not doing my day job is as a clinician in the local hospital. This is not a research hospital, it's an ordinary district hospital in Kenya, and looking after children. I've done that until 2 years ago for 25 years. When I went to Kilifi Hospital in 1989, it was a hospital that many of you may be familiar with, the kind of hospital, very poorly resourced, very poor infrastructure, very poor staffing, wards full of very sick children. And one of the things that struck me then was measles. Now, I don't know how many of you even ever see measles. I hardly saw it in my training. I had it as a child. We think of it as a mild disease. It's now largely gone from Europe, not from America, because people aren't very keen on vaccinating in some places. But measles in African populations is a devastating disease. It has very high mortality, and it's a horrible, horrible thing to see. And one of the most distressing things we dealt with was very large numbers of measles deaths, and many, many deaths due to common preventable infectious diseases. And the reason measles was a problem was that vaccination levels were very low. In 2002, there was a big push right across Africa to raise measles vaccination levels. Over 200 million doses of vaccine were distributed. What was the effect? I haven't seen a measles death in 18 years. I mean, it went literally from a massive problem to very, very low level problem, at least in the hospital we were working in. Over the next 15 years or so, this was repeated again and again with the introduction of different vaccines to the Kenyan health system. Haemophilus vaccines, pneumococcal vaccines, it doesn't matter what the name, these are just against various bugs, and always having a major effect and reducing the number of deaths due to those diseases. Now, malaria is something I'm particularly interested in. There isn't or wasn't a vaccine for malaria, but there are many easily implemented approaches to controlling malaria. From 2000, there was a massive international push which took global funding from $200 million a year to $2.5 billion a year. And this has led to implementation of malaria control across Africa. The impact has been extraordinary. Probably 8 million childhood deaths saved in the last 15 years. In the hospital I was working in, we were working there because I am a malariologist. The wards used to be packed full of children with cerebral malaria, many deaths a day. It reduced by 90% over the last 15 years to the point where malaria is quite an unusual thing to see in any numbers. So the picture I've just presented is of a transition over 20 years in front of my eyes, as it were, day to day, and we often don't notice things that are happening in front of us. The overall childhood mortality in that part of Kenya has dropped in 20 years by 75%. It's extraordinary. It's something I would never have believed would happen. Now, you might say there's something odd about that place. Maybe it's because we were doing research there. I'd love that to be true, but it's not true. This is a general pattern right across Africa. Childhood mortality and childhood death rates, which is a very important indicator of a health system overall, have been transformed by the level of about 75%. And it's a thing which many of us just don't notice, or at least when we're giving talks, fail to recognize that there's been a massive transition. The second part and final part, it's a very short bit of my case history, is related to and comes to a similar conclusion. I said there was no malaria vaccine. Well, in fact, many of you will know there is now a malaria vaccine. It's not a brilliant vaccine, but it's going into sort of large-scale implementation in some countries. We were involved in a lot of large trials of this. One of the striking things was that when you look at the results of the trials of the malaria vaccine, there's really quite a marked reduction in numbers of cases of malaria, but no reduction in the number of deaths. And this is really hard to understand because malaria is a major cause of death, but it becomes obvious to understand when you look at the overall distribution of ill health in the populations involved. And that is that whenever there's a large-scale trial of a malaria vaccine, or in fact of pretty much anything else like that, the health of the population as a whole is massively increased. So not only in the vaccine group, but the non-vaccine group. There were hardly any deaths anyway due to anything. You might say, well, what's the connection? Well, the connection here between the first bit of the narrative I told you, the reduction over time in childhood deaths in Kenya, and then the lack of deaths in the malaria vaccine, it's for basically the same reason. In each case, this was just the implementation of simple, available things we know about very well, like vaccination, availability of drugs, reasonable staffing levels. The reason it happened in the malaria trials was that you can't ethically do a trial without providing those things. So this has been repeated over and over again. And so my kind of, if you like, although I do think the future of health in Africa will be very different, I think there's a very simple and a very optimistic message, and it's been shown over and over again. And that is, without any new technical innovation, without any fancy new things, if we just simply did what the system is designed to do, so it's a health system issue, you would reduce childhood mortality and other indicators very markedly. And there's one really shining example of this, which many of you will know about, and that is, how was it that Cuba, one of the poorest countries in the world, achieved better childhood mortality rates than America at a time when it was right at the bottom of the league? And it's still the case. It's still the case that the childhood indicators in Cuba are better than in the USA. And the answer is what I've just been talking about. It's the implementation of simple, available, known about approaches to a health system that works. And so that's the conclusion I want to draw from my experience, is that of course we should be doing new things, we should be looking at new things, and new things will transform health. But the one thing which is transform it right now is simply do what the system is supposed to do, and that's the one thing which is often missing.
Thank you very much, Kevin. Dr. Nour, please go ahead.
Good morning. So there's a couple of things I wanted to talk about. Originally, I was born in Sudan, so I grew up in Sudan and Egypt. And when I told my father that I was coming to this conference, he said, make sure my father who is Sudanese, make sure you tell them you are Sudanese. So I'm Sudanese, which was, I should have put as a first part of my resume, I am Sudanese. But I practice medicine in the US. I'm also the director of the Global Women's Health at Harvard Medical School. So I straddle two worlds. And the conference today is all about reframing. And I wanted to start you on a journey first. So instead of me providing you with a case, I want you to be the case. So can you remember the last time you went to see a physician or a health provider and how you felt when you saw them? Were you able to explain to them what was wrong with you? Did you feel that they understood what you said? Now think about another time that you may have gone to a physician or a health provider where it was in a different country. It wasn't your home country, it was a foreign country. And let's assume that that provider could speak your language. Were you able to explain things to them? Were they able to understand you? And were they able to heal you? And now think about going to another country where you don't speak the language, the health provider that you see doesn't speak your language at all, and there is nobody in the room who can translate for you. Do you think that that health provider was able to understand your problems? Did you feel like you got excellent care? And do you feel that you were well understood? And that's the problems that I tend to see at the African Women's Health Center and in the US. So when I first started practicing medicine, I was a resident at Brigham and Women's Hospital. And at that time, I started noticing that there were patients from Somalia and Sudan, Ethiopia, Eritrea, who came in frightened, alone, and their health provider didn't speak their language. I'm an OBGYN, and the majority of the women that come to see me have very, very personal problems. So what do we do as health providers? Initially, we relied on family members. So again, for those of you in the room who have very personal, private medical issues, Do you really want a family member to translate for you? Do you want them to know your personal problems? As time went on, it was very clear that we needed medical interpreters, and that became a little tricky because what we don't always realize is that when immigrants and refugees come from countries, they come from countries where there is either famine or war. And so then you have interpreters who may come from the wrong tribe. Do you really want to talk about your medical problems to the person who may have been somewhat responsible for health issues or deaths to your family or your own tribe? The trickiness of medical care has so many nuances. We talk about cultural competence, we talk about linguistic competence, we talk about providing quality care, but how can you provide these types of care when there's so much complexity when the patient comes to you? Now I want to talk a little about the fact that when this first happened to me, when I first saw it, I was in a refugee camp taking care of Eritrean refugees who had come over the border in Sudan. I was working with Save the Children UK, actually, at the time. And it was then that I started recognizing that you can't provide excellent health care unless you really understand your patient and your patient's problems. So I want to bring that around a little bit to now. We started the African Women's Health Center. We have culturally competent interpreters. We have an interpreter phone, which creates a kind for patients who don't want a physical interpreter. We have interpreter phones that create a kind of invisibility so that people don't know who they're talking to and they can actually divulge their health issues. But let's talk a little bit about the global health issues. I know we had mentioned female genital cutting, which is really what I tend to do, but also I deal with maternal mortality, vesicovaginal fistulas, child marriages. And much like what you say, I agree with you, we're heading in the right direction. When you talk about reframing how medicine is, obstetrics and gynecology is improving rapidly by very, very simple things. Not vaccinations, but very simple maneuvers and education to health providers in places like Sudan and Egypt and Somalia. The thing I'd like to end with is just sort of looking at it one more time. So we feel like we're heading in the right direction. And I am very impressed that since I've been here, no one has mentioned the T word, which is kind of interesting. Because we talk about the T word every single day, maybe 100 times a day. Does anybody know the T word? Trump.
Oh, yeah.
And Trump has really impacted our healthcare system and really impacted my patients. So given the travel ban, my patients were directly impacted. Now, here we have very healthy, comfortable women traveling down the street wearing hijab or something that looks like they are not from the US, and suddenly there is a sense of fear. And so now we have moved back a little bit when we thought we were moving forward. Global health is global, whether it's in your home country, whether it's in Africa, whether it's in the United States, it is all global health. Thank you.
Mosa, please go ahead.
All right, thank you. This session is getting intense. I'm going to try and take it up a notch as well. The subject that I'm going to talk about is, I'll stand as well, is quite sensitive, largely because it involves issues of culture and so forth, and people don't like to talk about that. But, thank you. But I find it easier to talk about sex and sex work and HIV than to talk about this topic, and you'll understand why. I think for me the point of departure is that global health for those of us who are practicing global health or who are planning to practice global health, we need to be clear as to where we're coming from, our point of view. Are we doing global health for ourselves, for our own context, for our own countries, or are we doing it for the recipients, for the people that we are serving? Let's just be clear about that. So one case study that I want to bring to introduce, it's working? The first thing that I would like to introduce is this pathways of care, work that we've done previously and kind of pulled the evidence together to demonstrate that people use multiple sources of healthcare. And when we're coming from a particular point of view, say a biomedical perspective, we tend to see only the hospital, so it works. Just go back. One more slide. Yeah. So we tend to see only the district hospital, the clinic, the HIV clinic, and the ART clinic. We don't see these other sources of healthcare because of a particular point of view that we're coming from. But that point of view does not truly represent the views of the people that are receiving healthcare. And so we have to reflect on that. Failing to see that means that we are not going to recognize the delays that are caused by the complex systems that people use to engage with healthcare. And if they don't show up, we think that they've disappeared, but actually they're seeking care elsewhere. And we don't necessarily integrate those systems because then our point of view and our point of departure is that they must come to our own clinic, which is the HIV clinic, for example. Can you just go to the next slide? The problem with this is that if you take a community of about 160,000 people, you'd find that there's about 16 clinics, like in this typical community that you see here from South Africa. And it also means that a community of about 10,000 people on average gets one clinic, which is a ratio that's much lower than what you would expect for what the WHO recommends. And it's made worse by the fact that if you, sorry, my slides are flipping. Just one more slide. No, go back. One more slide, go back. If you look at this clinic, for example, it's not necessarily integrated in the community because here you have traditional healers. All these doors represent traditional healers who are much more embedded in the community than the health facilities themselves, right? So even though the proportions may even equate those of the need in the population, the location of these facilities are not necessarily embedded where they are supposed to be. So that is another problem. But to take it even further, if you go to the next slide, I'm assuming that global health comes from the perspective of biomedical practice. It uses a scientific lens. The evidence that we use in global health and public health is that of science, which appears to be in conflict with indigenous knowledge lenses. But the reality of the situation is that the people who are recipients of care tend to look at life also from indigenous knowledge lenses. And these two lenses are in conflict and they don't integrate. How are we then going to optimize global health if we are going to pretend to continue burying our heads in the sand like ostriches, as if the indigenous lenses don't exist? Now, my point of view is that we are also then not using the local resources that are available. You've seen the number of traditional healers that are there in the community. We're not engaging them, we're not working with them, we pretend they're not there. In fact, we try and discourage them from seeing patients. But there's multiple of them, and as we're saying that simple solutions could help improve health and overall well-being, we're not necessarily tapping in those local resources to try and improve health. Final slide. So I want to suggest to you that the future of global health should think about reconciling the difference between scientific knowledge lenses and indigenous knowledge lenses, such that the people who are the recipients of healthcare within global health and in communities that we visit can benefit from a broad array, a wide spectrum of sources of care and support in order to improve their overall well-being, not just their biomedical well-being, not just their mental well-being or social well-being, but also spiritual well-being. As uncomfortable as it sounds for someone who is from a biomedical perspective like myself, the reality of that is that it's not about me, it's about them, right? So global health for the people needs to benefit the people, whether I agree or disagree. And for things that I don't understand, I need to learn about them and get into my zone of comfort and engage with these people to learn about what they believe and integrate that into my global health approaches. I'll stop there, thanks.
Thank you all so much. I think we've been given three very, very rich and very dense case studies in such a short time. Now, I think that I'd just like to raise a couple of provocations before we open up to the floor. The philosopher, writer, and post-colonial theorist Frantz Fanon famously once wrote that depoliticized public health is not a discipline in the real service of humanity. And I think we should take that question seriously. And there are kind of perhaps three provocations that came to mind as I heard each of you speak. Kevin, I was greatly encouraged by the story that you told. We moved away from a kind of pessimistic, downbeat account of Africa's health trajectory. And you've shown us in quite a compelling way that simple things, getting our systems working right, can make a huge difference towards African health. Let's push on the example of vaccination a little bit further. There is, of course, a counterfactual argument here. Many historians have, of course, written that the money that goes into technologies like vaccines might be better off spent into more horizontal measures, improving primary healthcare, and even further, greater investments in things like sanitation, housing, draining water swamps, and so forth. So it's just something to think about. I think this controversy is highlighted, say, over attempts to eradicate polio. Do we focus on a polio vaccination, or do we focus on improving the living conditions of those who are most affected by this disease? Just to comment briefly on, Nawal, your presentation, I mean, the work, again, that you do is truly extraordinary, and I think you give us a very evocative account of what it means to seek healthcare and the intimacy and vulnerability that occurs within the consultation room. The provocation I have for you is one of voice. You know, we're talking about gender, we're talking about issues related to women's bodies, we're talking about some of the most politically visible and contentious issues. When we mention female genital cutting, we certainly have international campaigns around the world trying to highlight what are considered to be abhorrent practices. Who has the right to speak? What kind of forums do people have to share their experiences? How do things like language and opportunity shape and structure those kinds of exchanges to bring us into a much more pluralistic and shared understanding of what it means to be vulnerable as a woman in the context of things like maternal mortality, reproductive and sexual health? And finally, Mosa, I think that you've brought with us one of the most pertinent issues. In all the talk of innovation and technology, we seem to be creating at times a dichotomy between the traditional and the modern. And certainly the biomedical model, predicated as it is on a certain conception of therapeutic universalism and modernity, in fact has a history and a root in a Western knowledge system. In other words, what we call indigenous knowledge is framed as local and parochial, but could there be more to it than that? If we start to integrate indigenous healing systems into our understanding of global health, can we raise a wider question? Can we begin to decolonize not only global health, but decolonize science? Can we start to think about how a scientific enterprise exists within a political economy of knowledge production that fundamentally privileges certain ways of knowing, certain ways of producing knowledge, and ignores others? So I think that's a provocation. But I think rather than inviting you each to respond to these provocations at the moment, I'd be very keen to hear what members of the floor have to say, and certainly if at any point you want to address the points I've raised, by all means do so. Can I just remind members of the audience, could you introduce yourself and just say your affiliation so that our speakers know whom they're speaking to? Okay. Yeah. Right here. Just turn it on. Is it?
Hi, can you hear me?
Yes.
Okay, great. Hi, my name is Amina Ibrahim, and I represent an initiative called Project Awareness Nigeria. My question is for the panel, particularly Mosa, is what do you think is the role of, or is there a place rather, for mental health in the primary healthcare system? So you'll find that, say, for example, people with terminal illnesses or just long-standing illnesses have, there's a mental well-being aspect to that, and that's not discussed at all in the realm. And also, I'm Nigerian, and what you'd find is people with mental health issues are characterized in systems called lunatic asylums, so it's not, there isn't, the stigma is there, and that's almost encouraged by the structure of the society. So if you could incorporate that in a primary healthcare system, I think that could go away towards helping that. So, but what do you think is the role for that, given all the challenges that we already have with the primary healthcare system?
Mosa, before you respond, I think let's take two more questions. So there are two burning ones here and then just behind.
Hi, so my question is for Mosa.
And please don't forget to introduce yourself.
My name is Bosola. I'm a systematic review fellow here at the University of Oxford. I do have my background in medical pharmacology and public health. And so I'm reading this book I just bought on my own, and it's a narrative of HIV/AIDS in Nigeria, set in Nigeria. And it was written by Uzodinma Iweala, and it was talking about the stigmatization and everything. And I feel like South Africa is one of those countries that have like one of the highest prevalence of HIV in Africa, I think. So my question to you is, since the discovery of HIV/AIDS up to now, 2017, how has the progression been like in terms of stigmatization and educating people about HIV? Do you think we've made much more progress? Do you think more can be done? That's it. Thank you.
Okay. So we've had two questions for Mosa. McKenna, have you got a question for one of our other panelists?
I've actually got a question for Nawal.
Oh, perfect. Okay, you go ahead.
So my name is McKenna. I'm a biochemist by training, but I currently run the Africa Oxford Initiative, managing collaborations between Oxford and African institutions. And I'm interested in your thoughts about maternal mortality rates. I mean, there's been an interesting conversation happening the other day in the UK that the rates of maternal deaths have gone much lower than age-matched rates for male deaths. So much so that a man is more likely to die during the time that the woman is pregnant than the woman. And I find it really interesting that we have a kind of way of studying maternal health from a very Western kind of point of view. A good example that comes to mind is studies on preeclampsia, where they look at women of African ancestry being more prone to preeclampsia, but the women they look at are black, black is loaded, African-American women or black British women and so forth. So how does this translate in us having a hope to at least reduce maternal mortality rates?
Okay, so let's take those three questions just to begin with. Mosa and Nawal, and then the rest of you, can you begin thinking for some questions for Kevin as well?
Very happy listening.
Okay, so on the question of mental health, it's an important question. One of the things that I read last year as I was writing a review for the South African Journal on Traditional Healers was that the history of colonization affected the way traditional health practice was conducted. It was much better organized before colonization happened. But then there was a phase when people who were diviners or sangomas and so forth, people who basically connected with the ancestral world and so forth, were basically seen as mentally ill and accused of mental sickness. And as a result, that practice was driven underground and into the backyard, and people were being arrested. And there were several countries have laws that basically argues that people who connect with ancestry and so forth should not practice. And that's why it was also labeled a lot around witchcraft. And that's how we came to call them witch doctors and so forth. And so the issue of how mental health is handled at the community level is very different to the way we handle it in the healthcare system. generally health in general, including mental health, is a shared problem in the community. People tend, or in the family, it's not necessarily an individual problem. But the way we approach mental health, we make it a specialized problem, which is individual. There is a move currently to differentiate between psychiatry and mental health. And we're seeing that people are now kind of accepting that mental health is more of a district level hospital, more of a primary healthcare condition to be managed. And others are pushing for it to be community-based, so that the community can take collective responsibility for those people, and those people must not then be taken to jail and so forth. And so there's a lot of movement around it. There's a lot of new legislation that is coming, even in South Africa, around those sort of issues. But I don't think enough conversation is happening, and I don't think that our policymakers and people who make decisions have enough information or understand enough about strategies that could be used to handle the problem. So a lot of work can be done in terms of decentralizing it to a manageable level and make it safe as well for both the community and the people who have illnesses. And another question to think about is how conditions like depression are actually understood by many people. There's a whole lot of issues around that. In terms of HIV, there's been a lot of progress in terms of access and treatment. We were talking about this at a meeting last week here in Oxford at Green Templeton about the fact that stigma evolves over time. What we saw as stigma in 1999 is no longer the same thing that we saw again in 2003, in 2005, and so forth. And it's also difficult because stigma is propagated by people who are health workers as well, right? We tend to label things and attach names to things and so forth. But overall, stigma is still a problem. The fact that there's still a lot of people who don't want to go to the clinic because they're going to be seen, they're going to be labeled and so forth, even though people accept that HIV is no longer a death sentence. There's a lot of stigma reduction interventions that are needed. And in one of the papers that we wrote last year, we argued that traditional healers, because they are used as a sanctuary, people who are afraid of stigma in the clinic, they go to traditional healers and faith healers. We said that they must be involved in dealing with stigma reduction. But that conversation is not yet taking place.
Thank you. I just wanted to mention one, I know it wasn't a question for me, but mental health, I think, is a big problem, whether it's back home in Africa or even in the diaspora. And I love the fact that we're using the word mental health and not mental disease. What we are seeing in our populations of the diaspora is that the sense of isolationism, the sense of the fact that people come and feel alienated and now are being rejected creates such a large issue with depression. And I would say about 20 years ago, people didn't want to see a psychiatrist, so we spent a lot of time trying to reframe mental health and the concept of having social workers, people who will actually just talk to women, talking about giving them a voice to be able to speak. And so I'm very glad that, mental health is part of our discussion, which hadn't been for a long time. When it comes to maternal mortality, some of the very simple things, I worked with WHO, and some of the very simple things that we're now able to do is sort of uterine, a lot of maternal mortality was postpartum hemorrhage, bleeding right after having a baby, or the infections right after having the baby. And those very simple panaceas of uterine massage or being able to diagnose it early has helped us. Preeclampsia is a risk factor, or moreover, eclampsia, the seizure itself, not so much the pre portion of it. And we do see that is an issue, but it was mostly postpartum hemorrhage and improving that. We shifted over from traditional birth attendants to skilled birth attendants to be able to significantly reduce maternal mortality. The studies have been on African American women that got people to highlight it, but my experience when I was working in hospitals in Sudan and even in Nairobi is that eclampsia does exist. And I think it's more so not to say, why are we talking about color or ethnicity, but rather, why don't we just look at the disease itself and diagnose the disease and prevent eclampsia, because that does lead to maternal mortality.
Great. Let's take another round of questions. Now, I just want to remind you that we have about 7 minutes remaining, so please keep your questions very, very pithy. I saw, Kevin, you had a question from the previous round.
Hi, my name is Kevin Miners. I'm doing a PhD in mathematics at the University of Bath. And my question is, can we talk a bit more about the similarities, differences, and possibly conflicts between public health in the diaspora and in the continent? Can we talk about that? Thanks.
It's a great question. Okay, so let's see. Let's get a question from the middle and then a question from the back, and we'll come to you.
Hi, my name is Diego. I'm part of the research team of the Mo Ibrahim Foundation. My question is for Mosa. Like, your talk reminded me of Afrobarometer, like an Africa-wide public attitude survey, whose last results show that Africans trust more traditional forms of leadership than like their governments, their politicians. What would you say, like, is the role that policy can play, and like our governments, like African governments, can play to kind of like promote this approaching between like science, in this case, like medicine, and like traditional forms of leadership? Thank you.
Okay, we had a question at the back there.
Yes, thank you. My name is Medi Segawa. I'm a director of my own company. It's a recruitment agency, Zen Integrated Services. Now, my question goes to the gentleman sat next to you. Okay, he hinted on
Professor Kevin Marsh.
Yes.
Please go ahead.
Okay, thank you for your presentation about malaria. Well, my background is I did a degree in clinical medicine, and right now I'm pursuing a master's degree in natural health science. Well, I like alternative therapies. When you look at malaria, I'll give you an example. There is a video going around on YouTube. This was a research which was conducted by WaterAid and Red Cross. And you find actually they were doing a research about healing malaria using chlorine. They use chlorine dioxide, something like bleach actually, but in small concentrations. And the results were amazing. Within 24 to 48 hours, the malaria parasites were cleared from people's bodies. However, the research actually never came to the mainstream, because I think if you look at the mode of medicine, it has been hijacked by big pharma. So that's so. And then the other question is.
I'm sorry, I'm afraid we're going to have to keep it at one question, because I've got two more burning questions that I want to take in this round. So we have the woman here in the third row from the front.
Thank you. Thank you for your excellent presentations. I'm Abna, an Oxford student with the MSc in International Health and Tropical Medicine, originally from Ghana, a pediatrician. So my question is to probably either of the panelists. What are your ideas on sustainable strategies to deal with the issue of no data, especially coming from Africa, in terms of, and that seems to be the perspective of the rest of the world, so that now we can have research that is generated by Africans about Africa, taking into consideration our context and then trying to solve our own health issues.
Okay, and let's take one more from the gentleman in the front here.
I'll say something.
My question is for you, Kevin. What is the balance between the conducting research studies and for the benefit of the patient? As I'm thinking in regard to drug resistance in Africa, because mostly researchers tend to, the speed at which research is conducted, what are the findings in terms of how conclusive are the findings in regard to how that might affect patients in Africa? I'm thinking especially for children in malaria, for example. That's it.
Great, thank you. Okay, so if I could remind our panelists also to be very, very pithy in your responses.
Okay, I'll try and be pithy for three of those questions. I think it's essential that all research is formulated around an actual problem as perceived by the community, and the community from the people affected right through the community of practitioners through to the policymakers in the country. So it has to be formulated in that way. There's no room for research which is, as it were, academic research for somebody's interest because this might be nice to know and would inform things elsewhere. It's great if things inform things elsewhere, but I think it starts from the formulation, the context, and the reasons why you're doing that research, and I think that's really key. On the data issue, the only solution to that is to have data. I mean, it's just not acceptable to not have data. It's not acceptable for health systems or governments to allow a system which doesn't generate data. Part of the surveillance is conceptualized in the Global Technical Strategy for Malaria, for instance. Surveillance is categorized along with drugs and bed nets as an intervention. That's to say, without that intervention, you're lost. So I can't give you a magic shortcut to data. If you haven't got data, we're lost when it comes to formulating questions and answers. On the malaria drugs issue, you know, people love hitting big pharma, and I'm not a defender of big pharma, but that really isn't the reason that chlorine is not used as an antimalarial, because there are very good public-private partnerships which are looking exhaustively at every possible antimalarial, and they include some really interesting ones like methylene blue, which you might also have been referring to. People are desperate for new antimalarials, and there's no big market, it's true, for some big pharma companies, but that's not what's stopping things going ahead. If something works, it will go ahead because of the public-private partnerships. I'd be really confident about that. Yeah, interesting.
I think I want to say that we are doing much better in regards to data. So for example, on women's health, we had no data a good 10, 15 years ago on certain areas and certain diseases. Even things that we thought vesicovaginal fistulas as a cause, what really is the cause. And what's encouraging me are you guys coming out with innovative ways to collect data. And so now we have research projects where iPads are going around in the middle of villages, or the fact that mobile phones are being used to collect data when in the past we didn't have that ability. So thank you, young people, figuring out how to do this has enabled us to get the data. And I think even issues with when we were trying to gather data on how to stop FGC, it's that kind of, every year we come out with more and more data. So the fact that there is no data doesn't mean that next year we won't have it. I think I'll let you say that.
I think to answer both questions, we need to have the capacity to handle data. Ask the right questions, pull data. I was just telling Hannah that I'm currently learning how to use longitudinal large data sets in terms of combining them and pulling them and analyzing them, but the right questions as well. The leaders in policy, they need the evidence. Currently, they don't have the evidence to justify policy changes. And that data is necessary in the analysis of it. I also think that we need to also broaden the idea of leadership to include traditional and local leadership as well as we approach advocacy strategies that we use. The whole public engagement movement, which is taking shape globally, it's really important in terms of translating data into policy and practice and evaluating that. And I think in terms of the question of how experiences differ between Africa and the diaspora, it's a complicated question, but I often say you can take a man out of the village, but you cannot take the village out of the man, and it goes for the women as well. So think about that. I think that people over time tend to modify their values and they diversify and become cosmopolitan and so forth. But at the end of the day, we don't want the kind of global health that is going to erode people's values, and instead of actually building on those values. Thank you.
Okay, so I'm being told that we need to wrap up, but I'm going to be very cheeky here and just take one last question. So if there's a burning question, okay, our hand is already shot up. So we'll do it on the first come, first serve. Please, if you could give us the last question.
It's coming.
Okay, thanks so much. My name is Jerry. I'm one of Ashinaga scholars from Ethiopia. So my question goes to Nawal, the point you mentioned about maternal mortality. So as we know, it's one of the biggest public health problem in Africa. So I would like to know your opinion, how you related to with child delivery service in Africa, because I believe it's one of the main causes for maternal mortality rate growth. So how do you relate it to that?
Yes, so maternal mortality is such a devastating thing for not just the woman herself who passes away, but the whole family, because you have a child that may or may not have just been born. You have perhaps a family of kids that are toddlers going up to 10, and then you have the father. So maternal mortality impacts the whole family and can be incredibly devastating. There are simple solutions. WHO came out with guidelines on just simple solutions on how to prevent maternal mortality. And that is, you don't need a physician to be able to do the delivery. We can use skilled birth attendants who are trained to be at the woman's side to diagnose if there are any issues, if there's any complications of hemorrhage, if there's any ideas that she might be febrile, so she has a fever, any concepts of eclampsia, preeclampsia. Other things that lead up to maternal mortality are things that nobody wants to talk about, but these are unsafe abortions that occur in the home in a private section. So being able to provide family planning, which is just simple family planning, can prevent a woman from dying. I think that what is optimistic is that we have changed. I think we are really heading in a direction. I used to, in my talks, I would say it's like a jumbo jet crashing every day is how many women die per day. That's becoming less. I think the Millennium Development Goals have really impacted, and I'm very, very optimistic about the Sustainable Development Goals as well. One of the tricks, I think, going back to what we've all been saying, which is using the making sure that you're integrating and collaborating with organizations or with people in ground is critical. One of the tricks that I did, I was asked to edit a book, is I said, well, it's nice to edit a book and write something about how to take care of women in these areas, but what if there are no drugs? What if there is no IV? What if we can't get saline solution to be able to increase the volume of a woman? And so the book that we were able to publish is one that's very, very practical in a low resource setting when there aren't availabilities of all the HIV drugs. We're not practicing American medicine in Africa, we're practicing medicine that is available in each of these settings. But I think that's the end, is that you always have to practice what you have with you available. Thank you.
Thank you so much. And as an expression of thanks for the wonderful contribution you've made to the conference and to the session in particular, I believe the team has some gifts for you.
Wow, thank you very much.
And I just want to say thank you all for attending this session. I think that these questions and these debates of global health touch on multiple different facets as we think of the range of challenges that Africa faces in particular, but we in the world face all together. Health remains a fundamental quality of equity, liberty, and justice. And to have these three extraordinary speakers speak to us and tell us about the ways in which they conceptualize, challenge, disrupt, and continue to innovate in this area of work is both appreciated and extraordinary. So thank you so much, and enjoy the rest of the conference.